Hello, can you hear me?
Yes, ma'am.
I just wanted to check my audio again. Am I audible?
You are audible, but ma'am, your echo is there.
Who is there? Okay, so just give me a minute. How is it now?
Better, ma'am.
Okay, so that echo has completely
Yeah,
disappeared.
completely gone.
Okay, okay.
Could you just ask them to allow me to share the screen? I can start presentation. Could you allow me to share the screen?
You can share, sir.
Thank you. Good evening, Shafta. Good evening, Priyamoda madam. Welcome to the.
Yeah, good evening.
We will start the session exactly at 8 now. Initially, three of the moderators will be presenting 2 articles each, and at the end of the session, we will invite you to share your thoughts on the studies and the research can be replicated in the Indian setting and some of the. Yes.
So basically, like our comments are towards the end of the session, right?
Right.
After
Right.
all the 5
Correct.
or 6 articles has been presented, right?
Yes.
Yeah, okay.
Sir, it's 8. Shall we start? Go ahead with it.
Yes, I'm okay from my
I
side.
think we can wait for 1 more minute and
Okay.
then start. People are joining.
Okay.
Maybe 1 minute more and then we can start.
Okay.
I think we can start now.
Okay. Thank you, sir. Good evening, all. Welcome to the last 3 months in nephrology, the Indian Society of Nephrology Journal Club. Along with me is Dr. Arun from Delhi. Dr. Priyamvada from Puducherry, Dr. Shyam Bansal, Indian Society of Nephrology Secretary from Delhi, and Dr. Vivek from Chandigarh. Last month, in solidarity with the incident at the RJK, we skipped our session for the Eyes and Journal Club, and we are restarting from this month. I would like to share two articles. One from the kidney medicine. This was a single-center, double-blind randomized study. I'm not able to move my slides. Yeah, I think, yes. Okay, the first study is from the journal Kidney Medicine. It was a single center, double-blind randomized study from Thailand. Kidney Medicine is the official journal for the National Kidney Foundation. It has an impact factor of 3.4 and it's a monthly journal. This study talks about the use of cannabinoids as an antipruritic agent in patients with uremic pruritus. We do know that up to 50% of our patients on maintenance hemodialysis and end-stage kidney patients suffer from pruritus. Sometimes it could be a major cause for depression. The current medications are not great. Only 10% get complete benefit. Cannabinoids, with their anti-inflammatory, antioxidative, and peripheral nerve activation, have the promise to reduce CKD-associated pruritus. So when used topically, probably the systemic side effects of cannabis is also reduced. So based on the previous experience of using cannabinoids in psoriasis in patients with allergic dermatitis, this study was planned. So we do know that inadequate dialysis, uremic toxins, inflammatory, high PTH, dysregulation of calcium phosphorus balance, all these things contribute both through the opioid receptors as well as histaminic pathway. It's the opioid disbalance which is the most predominant pathway for pruritus, unlike the histaminic pathway. So the current treatments basically includes local treatments like moisturizing creams, ensuring that the cause for pruritus is uremia and not a fungal infection, and ruling out all these things. Gabapentinoids are the go-to drugs. Antihistaminics don't work that effectively. The other drugs which has been proven is difelikefalin, and still the success rate is just 10%. So we have three types of cannabinoids: the endocannabinoids, which is produced naturally from our body; the phytocannabinoids, which we derive from the plants; and the synthetic cannabinoids, which is made in the lab. For this study, the phytocannabinoids was used. The study group used 5% cannabis oil, which is a combination of cannabinoid and tetrahydrocannabinol at a combination of 1.27:0.13, along with the cream base. So the basic idea was both the mast cell differentiation as well as aggregation and histaminic release will be inhibited by cannabinoids. And this is the pathway how it has worked after binding through the 1R and the type 1 and the type 2 receptors. It prevents mast cell differentiation. So the way the researchers examined the pruritus score was using a worst itching intensity numerical score, and anyone who has a score of more than 4 was only included for the study. And this is how the score, which is commonly used, 1 being the no itch and 10 being the worst itch. They also used some of the common dermatological specific quality of life questionnaire, that is the skin dex. This was only for the secondary outcome. The primary outcome was based on the WI-NRS, that is the numerical scale for the worst itching. The study said it was a single center, double-blinded, randomized controlled trial, which was placebo-controlled. The sample, it was prepared using a plant available in Thailand after heating it for 8 to 10 hours, and the cannabis oil was extracted, and the contents of the cannabis oil was measured through the HPLC method. Skin testing was done to see any allergic reaction, and 5% cream was used. Placebo was a pure cream with the same ingredients but without the cannabis oil. Sample size was calculated based on the outcomes of the first 30 participants. So the first 30 participants were enrolled. Based on that, what their score was, what their response was, then the sample size was calculated using 80% power, and they said that 60% patients were necessary for enrollment into the study. So any adult patient who is more than 18 years end-stage kidney disease on thrice weekly hemodialysis for more than 90 days were included, and the efficiency of the dialysis was ensured that the single pool KTYV was more than 1.2. And someone with a numerical rate scaling of more than 3 was only included for the study. Exclusion criteria was any pregnancy or cannabis allergy or any other dermatological diseases which inhibits the use of cannabis. So the endpoint was 4 weeks. At the end of 4 weeks, the outcomes were measured. Also, intermediate outcomes were measured at week 2. So randomization, it is a block randomization, 1:1. So 125 patients were screened, and finally 60 patients were included. There was no dropout in the entire study. 30 were randomized in each group. If you look at the basic demographics, both the groups matched. They were well matched. Only the diabetes were more common in the placebo group compared to the intervention arm. If you look at the mean score, both the groups, both the placebo group and the intervention arm had the main pruritus score. So just to cut short, if you look at the primary outcomes, the placebo had higher score at week 4 compared to cannabis. The difference was not much in week 2. By week 4, the difference started to increase. Patients on cannabis cream had lower itching score, lower pruritic score compared to placebo. Similarly, when you look at the secondary outcomes also, including the skin text, that is the quality score of health-related quality score, that also showed that by week 4, there was a significant difference. Similarly, compared to the baseline and the mean reduction, there was significant reduction by week 4. So this study demonstrated that cannabis-containing cream was more effective in relieving the severity of chronic kidney disease-associated pruritus than placebo. So it is the week 4 which showed a significant. The transdermal route emerges as particularly advantageous option, owing to the moisturizing property inherent in the cream base. So the strength of the study was it was a randomized double-blind controlled trial. First investigation into the efficacy of phytocannabinoids in the treatment of CKD-associated pruritus among hemodialysis patients. The limitation was it was a single center. Sample size was only modest, 60 patients, 30 in each arm. They did not measure cannabinoid levels in the blood, so you cannot conclusively determine whether systemic effects also affected. Lastly, the follow-up period was just 4 weeks. Definitely, this study demonstrated that cannabis-containing cream might be an effective treatment for CKD-associated pruritus, especially for patients who are not improving with antihistaminics or moisturizing cream and who cannot tolerate gabapentinoids. So some of the, this study can be easily replicated in our scenario because it's cost-effective, and I think the systemic absorption is not great, at least looking at the article and their side effects. So something this study can be replicated, especially the amount of pruritus in our population. So my next study would be was published in NEJM in the month of August. This is a randomized trial of intravenous amino acids for kidney protection. So the basis of this study was to increase the renal reserve in patients who are undergoing cardiac surgeries. It was again a double-blinded multinational randomized trial. The study was mainly centered in Europe. It had 22 centers in 3 countries published in NEJM. Looking at acute kidney injury is a common complication following cardiac surgery. Even mild to moderate AKI is independently associated with increased morbidity and mortality, including the increased risk of chronic kidney disease. So we have gone through this process of AKI, AKD, and CKD. So renal hypoperfusion is a major contributor to decreased GFR after cardiopulmonary bypass. In the context of renal hypoperfusion, infusion of amino acids may exert protective effects in the kidney by recruiting renal functional reserve. This is the basis, recruiting renal functional reserve for the study. So the population, basically adult patients who scheduled to undergo on-pump elective cardiac surgery and are expected to be admitted in intensive care unit at least one night after the surgery. So 24 hours in the ICU was one of the criteria to be included. Intravenous infusion of balanced mixture of amino acids. Basically, the balanced mixture contains 2 grams per kilogram of ideal body weight, a maximum of 100 grams of intravenous amino acids composition from the time of operating room, and it was continued up till 72 hours after infusion or discharge from ICU or kidney replace, or if the initiation of dialysis. Any one of the things, if either if the patient was discharged within 72 hours or if there was the initiation of the dialysis, the infusion would be stopped. So it is the initial perioperative period that intravenous amino acids was used. For the control arm, ringer lactate was used. Patients who were eligible again for 18 years or old for elective surgeries, and ringer lactate was the fluid which was used as a placebo. So the occurrence of AKI, severity of AKI, and the use of duration of renal replacement therapy and the all-cause 30-day mortality were included as the outcome measures. Primary aim of the study is to determine whether providing continuous infusion of a balanced mixture of amino acids compared to placebo reduces the incidence of acute kidney injury in eligible patients. We do know that amino acids, by reducing the afferent arteriolar resistance, by reducing the tubuloglobular feedback, it increases the renal perfusion, and it increases the renal reserve and reduces incidence of AKI. So the primary outcome was the primary outcome of the protection trial. This trial was known as the protection trial, was the occurrence of AKI within the first week after surgery. Secondary outcomes were the need and the duration of renal replacement therapy, the duration of ICU stay, duration of hospital stay, and the need and duration of mechanical ventilation, and all-cause mortality at day 30 after randomization. So any adult undergoing a scheduled cardiac surgery on pump expected to stay in ICU for at least 24 hours were included. If the person has been with the exclusion criteria, main was if he was on dialysis or CKD stage 4 and beyond, that is an eGFR of less than 30, were excluded. Other than that, the routine exclusions such as pregnancy or allergic reaction to amino acids, these are the patients who were excluded. It was again similar to the previous study. It was again a double-blind block randomization, 1:1. This was a web-based randomization. Multi-center study. The slide is slightly busy. In a nutshell, about 5,000 patients were screened and about 3,500 patients consented for the study, and they were included. Randomization in each arm was about 1750 in each arm. Almost 95% of the patients completed the study, and they were and were included for the final analysis. Less than 5% was the dropout rate. So if you look at the type of the surgeries, most of them had a mix of CABGs with mitral valve replacement or aortic valve replacement. So what is important is 2/3 of these patients required vasoactive or inotropic drugs. At the time of the surgery, intraoperative, if you look at this, 2/3 of these patients in both the arms required inotropes. So let's look at the primary outcome. The occurrence of acute kidney injury in the first week after surgery was 27% in the amino acid groups and close to 32%. There was about 5% difference in the intra-group. The secondary outcome, that is the percentage of the patients who were requiring renal replacement therapy, it was 1.4%, that is a stage 3 AKI, 1.4% in the amino acid group and the 1.9% in the placebo group. Mortality before discharge, again 1.9% in the placebo group and 2.2% in the placebo, 1.9 in the amino acid and 2.2% in the placebo group. So in the nutshell, if you look at the outcomes, what amino acid group had better compared to placebo group was incidence of stage 1 and stage 3 AKI. So if you look at that, the in-hospital AKI, the AKI in first week after post-surgery, both stage 1 and stage 3 AKI were relatively less in the amino acid group compared to the placebo group. But if you look at the overall incidence, about 30% of patients had AKI, and out of which almost more than 80% had more than 90% had a stage 1 AKI. So the incidence of stage 2 or stage 3 AKI were less than 10%, and about 30% of them had AKI overall in patients with requiring cardiopulmonary bypass. Other than that, the secondary outcomes were there was not significant. The intergroup difference was not significant. Only the primary outcome was significant. That is the incidence of in-hospital AKI. So if you look at the mean serum creatinine over the next 72 hours, you can see that the amino acid group had a lower serum creatinine compared to the placebo group, further stressing the recruitment of functional renal reserve. Overall, 70 patients in the amino acid group and 62 in the placebo group were in surgical revision for bleeding. There was no drug-related adverse events in either group. For the discussion part, continuous amino acid infusion related in significantly lower occurrence of AKI than that of the crystalloid solution, without any effect on the adverse event. A short-term amino acid infusion increases estimated GFR by recruiting renal functional reserve and may confirm kidney protection. In the study, the criteria was to use for up to 72 hours or shift out of ICU or need for RRT. Any one of that criteria, if it was fulfilled, amino acid infusion was stopped. The combination of improved renal medullary perfusion and improved glomerular blood flow may be a key factor in conferring such kidney protection. The specific beneficial diuretic and renal effects of amino acids have been confirmed in pilot studies involving patients undergoing surgery. Finally, in patients undergoing cardiac surgery, renal function reserve has been shown to be crucial predictor of AKI and the measure of kidney outcomes, and a protective protein load has been associated with improved long-term renal outcomes. Findings of decreased percentage of patients with AKI overall and with stage 3 are aligned with the above observation. So in conclude, the infusion of amino acids appear to be safe and effective for the prevention of AKI in patients undergoing cardiac surgery. The strength of the study, it was a large trial that was based on broad and clear inclusion criteria, including a representative population of adult patients undergoing cardiac surgery. There was 1/3 of aortic, 1/3 of mitral valve replacement, and 1/3 of CABG patients. AKI occurred in approximately 30% of patients, which is broadly consistent with the findings in the previous studies. And with our sample size calculations, similar numbers were included. The trial intervention is straightforward and could be readily translated into practice. The limitation was serum creatinine alone was used for diagnosis of AKI. The patients are representative of European population, and the population in low and middle income countries may be different compared to the European population. Yeah. So those were the, I would like to invite now Arun to, I'll stop sharing my slides, and Arun, if you're ready with your slides. We will take the questions at the end of the presentation.
I will list thank you, sir. So I'll be presenting two articles, one from Lancet and another from JAMA, focusing predominantly on hypertension, which have been published in the last 3 months. The first journal which is to be presented is from the Lancet, which is lowering systolic blood pressure to less than 120 millimeters of mercury versus 140 millimeters of mercury in those with high cardiovascular risk. This was done in China, and it was published in Lancet a couple of months back. It was a e-spirit study. So hypertension control has always been a contentious issue over the last few decades, in spite of multiple of large trials which have been published in the last couple of decades. The ideal blood pressure is still a contentious issue. The reason why we are concerned about hypertension is because it is the single largest modifiable contributor for both cardiovascular disease and premature death. Though we had the Accord, Sprint, and the Respect trials, they had discordant results, and there were some issues with the study design, making it a necessity for larger studies, and also a need to reproduce the Sprint results, because that was the first major study which had shown that an intensive blood pressure control had better cardiovascular benefits. So just before we go to our trial, the ACCORD trial was a 2x2 factorial design trial where intense versus less intense blood pressure control was measured in arms in which both intense and less intense glycemic control were also measured. Because of this, it was seen that the primary outcome was not statistically different between both the groups, that is the cardiovascular outcomes. There was a minor improvement in stroke rates of stroke in patients who had intensive blood pressure control. However, overall adverse events and mortality was high. One of the post-hoc analysis had shown that this mortality increase was because of the intensive glycemic control. But however, there was no major benefit for intensive blood pressure control overall in diabetics. So the other problem was this, it was underpowered for the blood pressure outcomes, and because of the factorial design, it had a confounding effect. This was followed by the SPRINT trial, which was published a couple of years back, which did not include diabetics, had patients over 50 years with a cardiovascular risk score of more than 10%. Again, comparing 120 millimeters of mercury versus 140 millimeters of mercury, though it showed that the occurrence of MI, stroke, and heart failure were reduced with intensive blood pressure control. There were some issues with the trial with regard to the unconventional methodology which they followed. This is regard to the blood pressure measurements. So they had an unattended blood pressure measurement, which is not the standard which is done. And this could have affected the overall measurements and the outcomes of the study. And they didn't include diabetics, who nearly form 1/3 of almost all patients with comorbidities in the population. So these were the two reasons why the SPRINT trial may not be generalizable. So with this aim, the eSpirit trial was planned. It was the effects of intensive systolic blood pressure lowering treatment in reducing risk of vascular events. It was an open label, blinded, randomized controlled trial, which was done in 116 sites in China, which included 103 hospitals and 13 community medical centers. And it was sponsored by the Ministry of Science and Technology. And the aim of the study was to compare the outcomes in patients with intensive versus standard blood pressure measurements on major vascular events in a high-risk population. So the inclusion criteria included patients who were more than 50 years of age and had 2 consecutive systolic blood pressures in the range of 130 to 180 millimeters of mercury. If they were on antihypertensive, the range could be smaller, as we can see. And in addition to this, they had to have prior cardiovascular disease in the form of ischemic heart disease or stroke, or they need to have at least 2 cardiovascular risk factors with like peripheral artery disease, abdominal aortic aneurysms, history of revascularization, and 2 risk factors among diabetes, age, dyslipidemia, or being a smoker. So this was the cutoffs which they had used for inclusion. Important exclusion points were that patients with secondary hypertension were excluded. Those with a 1 minute standing systolic blood pressure of less than 110 millimeters of mercury were excluded because these patients had already a lower blood pressures. They were not going to be useful. Patients with a left ventricular ejection fraction less than 35% were excluded. With regard to renal patients with EGFR less than 45 ml, proteinuria of more than 2+ in a spot assessment, patients with history of glomerulonephritis and treatment with immunosuppressive drug, and those with any organ transplants were excluded. So it did exclude a significant number of patients whom nephrology manages. So it 1:1 randomization was planned between both the arms, intensive and the standard arms, and the patients were followed up at 1, 2, 3 months, and then 3 monthly for 3 years. Omron blood pressure measurements, office measurements were used, where according to the standard procedure, mean of 3 readings at 1 minute interval after a sitting of 5 minutes was needed. The patients were provided 5 classes of antihypertensives, as we can see, and they were provided free of cost, and the target BPs were achieved with either of these drugs. If at all blood pressures were not achievable with these drugs, additional drugs may also be used. The primary outcome of this study was a major vascular event, which was a composite of myocardial infarction, revascularization, hospitalization, or emergency room visits for heart failure, stroke, or death. Secondary outcomes were about death, composite of primary outcome and death, and a composite kidney outcome. The composite kidney outcome was defined as end-stage renal disease, a sustained EGFR decline to less than 10 ml, or a sustained decline of more than 40% from baseline. By sustained, they meant at least 2 readings which are 1 month apart. So the sample size, it was calculated presuming that the annual event rate is 3.4% with a 2% follow-up per year. And to achieve a hazard ratio of 0.8, the follow sample size calculated was 10,300. In this study, 11,255 patients were enrolled, and they were assigned to both the arms. And as you can see, nearly 5,600 patients were there in either of the arms, And the number of patients who discontinued treatment was 130 in the intensive arm and 38 in the standard arm, which was very less. Being an intention to treat analysis, all the patients were analyzed. The baseline characteristics is a busy slide. I have just summarized that. The sample size was 11,255, follow-up of 3.4 years with a mean age of around 65 years, and nearly 1/4 of the patients were over 70 years. We had 41% females, and at baseline, the blood pressures with or without therapy was 147/83 millimeters of mercury. More than 1/3 were diabetic. Nearly 1/3 were having history of coronary artery disease, and another 27% had history of stroke. The mean eGFR for the study population was 83 ml, and only 6% of the patients had a GFR between 45 and 60 ml. Just showing that most of the patients did not have any chronic kidney disease. So going on to the results, the systolic blood pressure in the trial arms, as you can see, they had achieved a very good control in both the arms. The intensive arm had a blood pressure less than 120, it was 119, as against the standard arm, which had a mean blood pressure of 134. One thing to note is that the standard arm had achieved their blood pressure of 134 by the second month, whereas for the intensive arm, it had taken around 9 months to 10 months for the blood pressure, for the intensive blood pressure to be achieved. This was because most of the recruitment had happened during COVID period, and at times home blood pressure measurements were being used. This was the explanation why they had taken a longer time to achieve the intensive blood pressure targets. Or the number of drugs required in each arm were obviously different. It was 2.1 in the less intensive arm, whereas 2.8 in the more intensive arm on an average. The only difference among drug agents which were used were diuretics. 42% of patients in the intensive arm used diuretics as against 15% in the standard arm. With regard to the overall primary outcome, in the intensive arm, 9.7% had a composite event for cardiovascular events as against 11.1% in the standard arm, and this was statistically significant. If you're going to go at the time point in which the primary outcome was achieved, we can see that though overall results is significant with a hazard ratio of 0.88, patients at more than 1 year when they were assessed, that is more than 1 year of intensive blood pressure, they had an even better response. The hazard ratio was only 0.78, which was also statistically significant. So this means that if the intensive blood pressures were maintained for more than 1 year, then the outcomes of the patients tended to be better. That is what they would want to say from this analysis. And if you're going to look at all the outcomes, almost all the outcomes were statistically significant with regard to death from cardiovascular causes, over primary outcome and death, and major vascular events. Only revascularization rates were not statistically different, or there was no protection of intensive blood pressure control over standard blood pressure control. This shows the absolute risk difference, and again the same thing is being shown. With regard to the renal outcomes which we are concerned with, 3 patients in the intensive arm had a sustained decline in eGFR. More than 40% they had, though no explanation was given for the same. This because the overall even number was less, this was not considered a very significant outcome for us, but the difference between both the groups was significant. With regard to the adverse events, it was comparable between both the arms, and only syncope and hyponatremia with sodium less than 130, they were more significantly higher in the intensive arm, but overall adverse events, serious adverse events, was comparable in both the arms. So overall, the eSpirit trial demonstrated that a significant decrease in major vascular events could happen with intensive BP lowering. Both the cardiovascular and mortality benefit was present, and it is beneficial for diabetic patients. This was something which was not shown in the earlier trials. The strength was that it had a large sample size, over 11,000 patients, a very good adherence, very few lost to follow up, and a large number of clinical outcomes. Apart from renal outcomes, the cardiovascular outcomes, the number of events were quite significant. Limitations being it is a Chinese study, so whether we can generalize it to the population elsewhere is a question. Follow-up of 3 years may not be significant enough for us to understand renal outcomes especially. The most important category of patients for nephrology were excluded with eGFR issues, and the use of home blood pressures during COVID is something which has to be seen. A meta-analysis which had included the earlier larger trials, the SPRINT, ACCORD, and the STEP trials, had also a similar result, wherein the overall incidence of cardiovascular events were low. However, it did not have any renal adverse outcome, and overall, only 13% of the patients in either of these trials had some degree of CKD, which just shows the therapeutic nihilism which we have with even the hypertension trials. This is just a comparison for us between all the major trials. The important factor is that only a SPRINT trial had eGFR up to 20 being taken, whereas the other trials patients of stage 4 were 3 and 4 were usually excluded. The numbers were maximum in the e-spirit trial. The differences between the blood pressure groups, it was very well established in the e-spirit trial. Follow-up was grossly similar in all the trials. The problem with sprint was that only less than 2% of the patient population were Asians, whereas in e-spirit 100% were Asians, if we include Chinese, obviously. So that is one. Overall, e-spirit has shown that there's an increased risk of sustained renal function decline. However, the interpretation is not, it is limited because the overall events were less. Almost all the earlier renal trials, they have also not shown any renal benefit with intensive BP control. And whether the renal dysfunction is because of a reversible hemodynamic change due to the reduction in blood pressure or because of intrinsic damage to the kidneys is something which we cannot tell. So the main conclusion of this trial was that intensive BP control to less than 120 meters of mercury systolic is beneficial across all categories of patients with diabetes, cardiovascular disease, prior stroke, or even in elderly population. The benefits are significant, especially after 1 year of treatment, and probably a long-term studies will help us. So they are also planning a 2-year extension study where probably they will help us understand if the renal outcomes are going to be bad in the subset of population. So this was the first study, which was from Lancet about intensive blood pressure control. My next study is again on hypertension. This is about hypertension and kidney function after living kidney donation. So right from the first study, probably a Swedish study in the 1970s, which had told that kidney donors live longer. It has always been a analogy that we always say that kidney donors usually have a longer lifespan and they are usually healthy. But there are questions about hypertension, chronic kidney disease, cardiovascular disease and mortality among kidney donors. And though the serious perioperative complications are very rare in the present era, and the 15-year risk of ESKD in the earlier studies has been around 0.5%. Earlier studies have shown that there may be a higher incidence of hypertension and albuminuria, but this is basically has a low quality of evidence. The higher risk among kidney donors, this can be because of the nephrectomy, one, because of the hereditary factors, considering that patients, the donors have family members who are having renal disease, there can be probably a cause for increased risk, and probably they are having more regular follow-up, which gives a greater opportunity for diagnosis. Nevertheless, there is always a need for better evidence on living kidney donor outcomes. And this study, it was done to determine if the kidney donors have more hypertension and worse kidney outcome as compared to matched non-donor control population. So the living donor safety study, it was a multi-center prospective cohort study, 17 centers, 12 in Canada and 5 in Australia. Recruitment was over 10 years. Sorry for the typo. It's 2004 to 2014. And they were followed up till November 2021, a median follow-up of 7.3 years. The study was sponsored by the Canadian Institute of Health Research, along with Astrella Canada and Novartis were the other sponsors of the study. Inclusion criteria was standard as we use for all donors. They should not be hypertensive, no proteinuria, no hematuria, and their BMI should be less than 35 kg per meter square, age from 18 to 70 years. With regard to the exclusion criteria, standard, if they are going to have any of the other comorbidities, they were excluded. If they are gestational diabetes, they were excluded. And if they are planning to become pregnant in the coming year also, they were excluded. So probably this relates to the population with which we use as a standard criteria donors. So what they did was that in the pre-donation, they had a recruitment kit wherein they are going to assess the eligibility of the patients, take an informed consent. General evaluation was done, blood and urine specimens were collected. This was then done at 3-month intervals, and then yearly it was done after the first year. And to make sure that the patients were retained, reminder calls were given, you had reminder letters, repeated contacts were done, and a home nurse visit was established. This was done for both the donors as well as for the controls in addition in order to reduce the risk of loss to follow-up. The outcomes which are assessed were hypertension. The standard criteria of 140 over 90 was used. The change in GFR, annual change in GFR, which was assessed at 1, 2, and 4 years based on the CKD-EPI equation. Albuminuria, the ACR was measured, and a composite of hypertension, EGF, and albuminuria was one of the outcomes. Composite of death, kidney failure, and a major cardiovascular event, including MI, stroke, was one of the outcomes. Quality of life was self-reported using the SF36 survey. And to assess anxiety and depression, the Beck's inventory were used. And self-reported tinnitus and sinusitis was also done. This was done because they wanted to remove bias. So it was to see if either the donors or the patients, they self-reported tinnitus or sinusitis. So if at all they were reporting it more without any clinical features, it means that there is a bias in the reporting of the patients to ensure that this was taken for the patients. So overall, with a event occurrence of 15% or 5% loss to follow-up, at least 900 donors and 390 non-donors had to be included for sufficient power. Number of statistical methods were used. We won't go into the details right now. We'll probably discuss one of them during our standard JCs in the next month. Number of changes were done in the change study protocol over the years. One thing, important thing was that instead of the 15-year outcome, an incidence of all the parameters at 5 and 10 years was given because 15 years data was limited. The health rated quality of life questionnaire was done in 3 years, and a sustained donor GFR of less than 60 minute at 2 intervals of 1 month each were assessed. These were the changes which were done after the protocol was published. That is why they have mentioned it separately. So overall, 924 donors were included and 396 non-donors were included. The most important thing about the study was the fact that the loss to follow-up was less than 5% of the donors and 10% of the non-donors were lost to follow-up. So this shows that the retention was very high for this study. The baseline characteristics, number of other parameters are overall collected for the patients. Significant was that there was a female preponderance, though as not much as in India. It was 66% in the study. It was a predominant white population, 84% whites, and the BMI was managed in nearly 87%. The mean age of the study population was 47 years. They were normotensive with a mean GFR of 100 ml. And 50% of donors and 25% of non-donors had a family history of kidney failure. And nearly 50% in both the groups had some genetic relationship to the recipient. So the non-donor pool was also patients or friends who had just come along with the donors or with the patient during the transplant process. That is why the genetic relationship, the percentages were high in both donors and non-donors. With regard to hypertension, it was seen that on follow-up, 161 donors and 158 non-donors had developed hypertension, and this was not statistically significant, the difference between both the groups. With regard to the eGFR, we can see that the donors expected their GFR predominantly was from 45 to 90, which is expected after kidney donation, whereas for non-donors, it was on the higher side. More than 60 was a standard one. Less than 60, only 4% had a GFR less than 60. And what is interesting is that in the donors, the initial GFR was around 100. It had dropped to 66 at the first year on an average. And over the next 7 years, it did not reduce much. It was, as a matter of fact, was increasing by 0.1 every year. Whereas in non-donors, it was 100. And every year it was reducing at around 1.2 ml per minute. At the end of 7 years, it was 90. So it just shows that around 1 year after donation, the trajectory of eGFR decline was much better with the donors than with non-donors. With regard to albuminuria, there was no significant between group differences. With regard to the composite outcomes, the composite outcome of hypertension, low GFR and albuminuria, it was 59% in the donors as against 29% in the non-donors. But this difference was because an eGFR of less than 60 was part of the composite outcome. Because most of the donors had a lower eGFR after donation, the risk of composite outcome also has increased. With regard to death, kidney failure, and major cardiovascular event, this was statistically different between the groups, and this was also because 9 donors had expired as against 0 among non-donors. This was the reason why this composite outcome was statistically different. And with regard to the cause of death, none of them had end-stage kidney disease. It was the donors had pulmonary embolism, sudden death. One could not be traced and one had a cancer, and it had happened over the 12 years after donation. So this was the reason that no one had a kidney failure related death in either of the arms. With regard to the health related quality of life, there was a significant dip in the first 3 months among donors. However, it bounced back, and throughout the end of the study, the donors had a better health related quality of life or near normal to the normal patients. And there was no significant differences in anxiety or depression between both the groups. So overall, both groups had a comparable rate of hypertension around 17% over the entire study duration. Earlier studies have shown that there is a higher risk of ESKD. Both the Norwegian study had 11-fold risk, whereas the US study had a 10-fold risk. However, we should remember that the overall event rates were very less. So it may not be a very true risk. And the current study is therefore very reassuring. One thing is that the donors are having a slower rate of eGFR decline after first year, which is good. And there is no increased risk of hypertension. And we should always obviously counsel them that the risk of end-stage renal disease is probably increased with male gender, black race, higher BMI, and pre-donation hypertension, which was from earlier studies and not from this study. Overall, the limitations being, again, it is a predominantly white-based study and a standard criteria donors were used. So if you're going to use borderline donors in Asian population, what is going to happen is still uncertain. Multiple protocol changes were done. Though we didn't discuss, there were multiple statistical adjustments which are quite complex, which probably could limit our understanding of this study. And though they had initially planned to have a 1:1 ratio between donors and non-donors, they could not have adequate non-donors. So probably their statistical efficiency is going to be affected because of this reason. To conclude, overall median follow-up of 7 years, risk of hypertension, albuminuria is not significantly greater in donors as compared to non-donors. The mean rate of EGFR decline is lower in donors. And if at all we use a guideline recommended follow-up testing and we maintain good long-term follow-up, I think donor health will be maintained well. Just reassures that donor risk of hypertension is less from this study. Thank you. I think Dr. Vivek sir will now present his study. Then probably we can have questions at the end.
Yeah, thanks, Dr. Arun. Share my screen. Good evening, everybody. So today I'll be briefly discussing two articles which were recently published over last few months. The first one is from Jason, and it is analysis of a large retrospective cohort from the Fresenius Medical Services that runs various maintenance dialysis centers across the world. And the analysis pertains to effect of dialysate in plasma sodium on mortality in a selected hemodialysis cohort. So we all know that end-stage kidney disease and chronic kidney disease are a state of sodium and fluid excess. And when these patients start dialysis, it offers us an opportunity to manage their sodium and fluid balance in addition to drugs by way of modulating sodium clearance through extracorporeal means by changing dialysate sodium levels. So, increasing or decreasing dialysate sodium has been a question that is perplexing nephrologists for decades now. And you have and we do have observational data and small randomized controlled trials, but still there is no definite answer as to whether high or low dialysate, which one of these is going to be ultimately beneficial for with respect to the fluid balance and ultimately translating into less cardiovascular risk and mortality. So this was a retrospective cohort study which looked at data of the Fresenius Medical Care managed dialysis clinics across several continents. The study included data from centers run by Fresenius company in 25 countries, and they have a very, very robust system of collecting standardized data of maintenance hemodialysis patients who are undergoing hemodialysis at their centers, and the electronic medical records of the individuals who were undergoing hemodialysis at their centers between 2010 to 19, they were retrieved. So broadly, they included incident patients who would start hemodialysis, irrespective of the fact whether hemodialysis was the first modality of kidney replacement therapy. And they included only those patients who have had one bioimpedance spectroscopy measurement, that is measurement of their fluid status, an objective measurement of the overall fluid status within first 3 months of the of starting the first treatment session. And they followed these individuals till December 4, 2019. And if anybody, either died or had a transplant or shifted to another facility, then his data was censored at that particular time. So the primary exposure variable was dialysate sodium, and for that they divided the study population into two groups: the one which had a dialysate sodium less than or equal to 138 millimoles per liter, and the other one which had more than 138. And the plasma sodium concentration was defined as the secondary exposure variable, and the population was defined as hyponatremic, isonatremic, or hypernatremic, depending on whether their sodium values fell in the range which are being shown on the slide. The primary endpoint was the all-cause mortality in these two groups, a comparison of all-cause mortality in these groups. And they also did subgroup analysis to see whether the all-cause mortality differed in different subgroups or not. They used a multivariable Cox proportional hazards model, and they stratified the results by country and also accounted for clinical variance. So over a period of almost 10 years, they had approximately 154,000 patients who underwent hemodialysis at their centers. And ultimately, they had values about dialysate sodium, serum sodium, as well as the bioimpedance measurements would be analyzed in approximately 68,000 patients, which translated into close to 21 lakh patient months of exposure. So these are the broad outcomes in the study population. They had a variable duration of follow-up, of course, because they continued to enroll patients till 2019. And over this variable period of follow-up, 32% had died, 9.1% had received a kidney transplant, 28.4% were still alive till the on the date on which the study was the collection of data was censored, that is 2019, and approximately 30.6% had withdrawn from hemodialysis. Now, if we look at the distribution of dialysate sodium prescription, you see approximately 1/3 had a dialysate sodium of 138, which was prescribed. It was only 0.4% which had a dialysate sodium prescription, which was less than 138. And in the other group, it was 139 or more than 139, usually 140, rarely 141. That was there in 15 and 20% of the population. And if we look at the regional distribution of dialysate sodium prescription, we see that it was something which was like a policy at the dialysis centers, that they would follow a dialysate sodium of almost 138 for almost all their sessions. So it was not like this that it was varying in centers. That is, they followed a fixed dialysate sodium policy, the individual centers, and it was only in a very less percentage of participants that the dialysate sodium was varied while they received dialysis over long term at these centers. So this is just a comparison of these two groups. As we can see, and as is expected, the patients were old, approximately around 62 to 63 years, and we had around a quarter of them having diabetes. Now, here are the results with respect to the primary outcome in these individuals, and overall in the complete study population, the hazard ratio for higher mortality was seen in the group which had a lower dialysate sodium, and it was to the tune of 1.57 as compared to the higher dialysate sodium group. And the effect was more pronounced in the group which had hyponatremia. And as we can see that the effect is consistent across all the three groups, but the hazard ratio for mortality was particularly pronounced in the lower dialysate sodium group. and it was approximately 2.56 in the hyponatremia group. Overall, for the study population, it was around 1.57. And if we look at the subgroup analysis, the results again were more or less consistent. So, so this is, as is true for any of the observational data, the main limitation is that if we look at the complete data set, then there was a lot of missing data which led to exclusion of a large number of patients. And there could have been some confounding bi-regional factors which could not be, though they try to, you know, statistically adjust those things, but it's not always possible. And as I just mentioned that it was a default sodium approach, it was not something which was individualized in patients. So this is something which could have confounded the results. And with respect to the dialysate values, dialysate sodium values which were used, it was like that these were the values which were entered in the machine, and it was not something which was actually measured. But there is already literature in this regard to show that the entered values and the measured values very, very closely correlate. So this is something not, I would not say a very big limitation. And within the low dialysate sodium group, as we have seen, the variance was low, as it was almost exclusively, 138 across the board. The main, I would say, the strength of the study is that this is a very, very large data set. But still, this doesn't lead us anywhere, because you have a result, which is not based on very, very sound clinical evidence. However, in this regard, we have an upcoming study which has been running for a few years now, almost 5 to 6 years. It's a multi-centric search study, RESOLVE study, which is being led by investigators in Australia, and India is also India also has a number of participating sites in the RESOLVE study, which is looking at dialysate sodium concentrations of 137 versus 140. And the results are likely over next 12 months. So hopefully we will have more credible evidence which would lead us to either one or the other side with respect to dialysate sodium concentrations. But this study, this large observational data suggests that and that keeping a higher dialysate, that patients who have had a lower dialysate sodium less than or equal to 138, they had higher risk of dying as compared to those who had a dialysate sodium of more than 138, and the risk was more pronounced in those individuals who had hyponatremia. So with this, I will go to the next study, and I think time is short, so I'll just quickly cover it. So this is a clinical trial which was published in Kidney International, and which looked at atacicept for treatment of IgA nephropathy. We all know that we have this 4-hit hypothesis for IgA nephropathy, where it's an abnormal mucosal response which leads to a defective electrosylation of the immunoglobulin A, subsequent production of autoantibodies against defectively electrosylated immunoglobulin A, and then deposition of these immune complexes in the kidneys. And since this is all related to defective production of autoantibodies and persistent production of those autoantibodies over a long period of time, which leads to disease. So logically, there is an interest in decreasing the production of these autoantibodies. And this is where, we have a promise in the form of BAFF and APRIL inhibitors, which are which can block the mature B cells and plasma cells, and can lead to decreased production of these autoantibodies, selective decreased production of these autoantibodies. So these studies are built on a large amount of evidence which has already been published with respect to role of BAFF and APRIL in pathogenesis of IgA nephropathy. So this was a multicentric placebo-controlled double-blind RCT. It was a phase 2b trial looking at initial efficacy and safety. So the trial involved 3 doses of atacicept at 150, 75, 25 versus placebo. It was to be self-administered at home by subcutaneous injection. The assessments were done at 2, 4, 12, 24, and 36 weeks. And as is true for any clinical trial in IgA nephropathy, you have the clinical outcomes in the form of change in urine protein excretion, change in estimated GFR, and of course, since safety is of paramount importance in a phase 2b trial, we would be looking at adverse events, overall adverse events, and of course, adverse events related to the drug. So they included all patients who have had a diagnosis of IgA nephropathy, biopsy-proven diagnosis of IgA nephropathy within last 10 years. It was not necessary that they should have had a biopsy within, let's say, 3 months of inclusion in the trial. The patients were. It was important for patients. It was mandatory for patients to have a 24-hour urine protein excretion of more than 750 milligrams per day. Or equivalent in the terms of UPCR, as well as they should be on. They should have been on, a stable ACE/ARB for the last 12 weeks, and patients with an estimated GFR of more than 30 were eligible. Patients with secondary IgA nephropathy, patients with associated nephrotic syndrome or rapid loss of renal function defined as more than 50% loss decrease in GFR over 3 months were excluded. And they were randomized to these 4 groups in the ratio of 2:2:1:2. And the randomization was stratified by baseline eGFR. Primary outcome was change in 24-hour urine protein excretion, whereas the secondary outcomes looked at, a change in UPCR at 36 weeks, as well as in individual groups versus placebo, as well as changes in, eGFR and serum levels of defectively galactosylated immunoglobulin A1, and of course the safety outcomes. So they screened 232 patients, and they had, 15 patients in the 25 group, 33 in 75, 32 in 150, and 31 in placebo for final analysis. And as we can see in the baseline characteristics of the study population, the average age was close to 39. And, you had fair representation of Asian population also. It was 44% of the participants were Asians. The average blood pressure was somewhere around 120, 130 to 80. And the average protein excretion at baseline was 1.6 gram per day. The average eGFR was close to 63. Now, this graph depicts the change in the primary outcome parameter, and as we can see that for the purpose of analysis, they combined the groups, the 75 and 150 milligram atacicept groups were combined and were compared against placebo to look at the efficacy. And as we can see that as compared to the placebo at 24 weeks, which was the primary outcome parameter, we can see that the proteinuria did decrease by 5 to 6% in the placebo, but the effect was much more marked in the atacicept group. It was close to 32 to 33%. And if we look at individually, also the effect was, the trend was similar in both 75 and 150 milligram groups. Now, with respect to change in estimated GFR, we can see that in the placebo group, the GFR dropped over a period of 36 weeks. The estimated GFR actually dropped by approximately 6 to 8%, whereas in the atacicept group, the GFR remained stable. In fact, it actually increased by 1%, but overall we can say that it remained stable. Now, with respect to the another important secondary outcome parameter, that is change in circulating levels of immunoglobulin A and the Gd-IgA1, we can see that with the use of intervention, there was an early marked decrease. It was to the tune of 60%, and it was there, in all the 3 intervention groups. The overall safety profile was good, and there was no increase in either adverse events or treatment-associated serious adverse events in the atacicept group as compared to placebo. Most of the side effects were related to local skin reactions, which at times were mild to moderate. Otherwise, it was not something that that questioned the safety of atacicept in the study. So this study again adds to the increasing literature with respect to this class of drugs. We have had a trial which was published last year in NEJM, in which also we had centers from India. It looked at APRIL inhibitor sibeprenlimab in IgA nephropathy, and it also showed a significant reduction in proteinuria. I think it was over 12 months, and stabilization of GFR. So we have a similar result here also, a different class of drugs, but targeting the same mechanism. It was safe, it reduced proteinuria, stabilized GFR. The data is short-term on only 36 weeks, but it's likely now we'll have a phase 3 study with this drug with a dose of 150 milligram. The major limitation, I would say, is that there was no biopsy at screening or enrollment, so we don't know whether proteinuria is related to active disease or it's just a result of scarring. Thank you.
So a couple of questions were there, and I think most of the questions has been answered. Darshan, can you have a quick look at the questions, and can you let me know whether anything needs to be addressed more? So meanwhile, yes.
Satish Balan sir was about the falsely low serum creatinine value when using amino acid infusion.
I'll come to that. Okay. So basically, that's about the protection study, right? Presented by Darshan. So basically, the idea of amino acid infusion was amino acid infusions are going to increase the renal reserve. And as per the existing knowledge, whatever reductions in creatinine we are going to see probably might be reflection of the increased GFR. Amino acid infusions are known to increase the GFR from 30 to 50% of the baseline values. So what I believe is whatever reductions in creatinine might not be just actually a mechanistic error or a mechanical thing that has resulted from the amino acid infusions, that probably might have resulted from the reduction in, improvement in glomerular filtration rate, which might have led to the decrease in the serum creatinine. But in a way that protection study is really interesting. This is where actually you should not be deceived by the p-values. And let us see what exactly has been done in the study. Around 120 gram of proteins was given over 48 to 72 hours, because most of the patients completed the protein infusions in 48 hours and they were shifted out of the ICU on the third day. And what they found was there was a 5% reduction in the AKI risk compared to the placebo, which actually translates to an approximate number needed to treat is 20. So that means you treat 20 patients, you're going to see a benefit in one. But eventually, this type of studies actually calls for a pharmacoeconomic analysis also. What are you trying to gain at the end of the study? You have reduced AKIs by 5%. But is there any reduction in the hospital stay? No, it's 7 days. And whatever reductions in AKIs were observed only in stage 1 AKIs. The number of stage 2 AKIs and the stage 3 AKIs are going to be very limited. Now the question is whether the stage 1 AKI is going to be a consequence or whether it is just inconsequential. We don't really know. At least by looking at the 180-day mortality, there is actually no change. What really matters is whether this AKIs early in the course of cardiac surgery is going to affect the long-term GFR. That probably needs really long follow-up, but as we know, there are two factors simply AKI related, apart from all the comorbidities and risk factors that actually play as the background of AKI. The AKI related factors that decides the outcome is one is the stage of AKI, second is the recovery of the AKI. So now in this particular study, probably the AKIs, the early stage 1 AKIs probably might not be of much consequence, because even the data which is available at 180 days does not really show much of a difference. So what are we gaining by giving around 120 or 140 gram of amino acid? Is it going to be cost effective? So that is going to be the big question that's going to be answered here. So any other question I should answer from the chat box? Yeah, there is something about the nutritional relevance, and obviously know that first 48 hours and all, in a completely controlled situation like an elective cardiac surgery, providing or withholding nutrition is very, very unlikely to affect the outcomes. So probably that is not going, that amino acid infusion is not going to have changed much of the outcomes if we just take that nutritional aspect alone. So I would like to add a few comments about the studies discussed. The first study was the cannabis study, a small study with a really good methodology and a really good analysis. But actually, one of the major drawback about that study was the unequal distribution of the diabetic individuals. So the placebo group had more diabetics, and the vintage of the itching was a couple of weeks more compared to patients who received the cannabis intervention. And in chronic conditions like this, perhaps 4 weeks is going to be a relatively less time frame for affecting outcomes, because chronic illnesses usually takes a little bit of time. So maybe if somebody is planning to reproduce the study, and obviously your sample size is going to yield you small numbers, but when the key variable like diabetes that is going to affect the outcomes gets distributed unequally, analyzing the data becomes a problem. So either you have to anticipate that, and you have to design your study, design your analysis in such a way that this should be answered, or probably you should go for a stratification according to the diabetic status. Then coming to the e-spirit study. Yeah, again, I would say the risk factor profile was possibly comparable to that of the sprint trial, but there is a marginally different outcome. Outcomes were slightly different compared to the sprint trial. And of course, a major difference was sprint trial used unattended blood pressures, and unattended blood pressure of 119 is not going to be equivalent to an office blood pressure of 119, because the white coat effect is again going to come up. So again, what we need to keep in mind is rather than jumping to 120 for all, if we see the mean blood pressure was 119 in the intervention group, that is the intensive control group, which actually means that at least 30 or 40% of the patients might be having values above 120. So, and there was a statistically significant increase in the incidence of hypertension and syncopial episodes. So possibly still, rather than blindly following that 120, what we need to take care is the overall patient comfort and overall patient tolerance. So we can actually go for a value somewhere around 120, but not really be insistent on reducing to less than 120. And as nephrologists, it doesn't really change much of our practice. If we look at this study, the overall GFR is going to be 83 or so. And there was very less number of patients with moderate kidney failure also. So now whether we can apply this to our patients, we don't really know. Maybe this is going to be more important in the primary care as well as the secondary practice. Probably the physician's awareness on intensive blood pressure control needs to be, this study probably should be popularized among the physicians, but of course, looking at the caveats also. And a detailed discussion is not possible comparing the ACCORD and SPRINT trials. And again, the study population, even though the GFR is comparable with the ACCORD study population had a much longer duration of diabetes, which possibly might be something that might be responsible. And plus, as Arun correctly told, the double factorial design. So we cannot assume that the intensive glycemic control and the intensive blood pressure will not interact. Obviously, they are going to interact in one way or other. So the hypertension and living kidney donation, there was a question on that increasing GFR. So probably the only explanation is the hyperfiltration probably runs for a couple of years. And if we look at the GFR data, what we can see that in the initial 3 or 4 years, there is a gradual increase in the GFR, like it more or less remains stable. And after that, there is a very minimal decline, but that decline is actually lower than what happens in the healthy population. And the study design is exceptionally good because they have done something called an inverse propensity score matching, which actually creates a pseudo population that is going to be comparable with the healthy donors, because most of the studies comparing kidney donors versus non-donors, most of the baseline characteristics are not going to be comparable. Sometimes the donors might be healthier compared to the general population, and the vice versa also can happen. So basically, by using a inverse propensity score matching, they have created a pseudo set of control population with matching characteristics as compared to with matching characteristics that are comparable with that of the donors. But again, what we need to keep in mind is 10 years is actually a very small time frame. Probably the effects of kidney donation might actually be apparent after 2 or 3 decades. So what we know is, at least in the short term, there is no accelerated decline in GFR, there is no increase in hypertension. So what we cannot tell is that, let us say, suppose somebody donates a kidney at the age of 40 years, whether the patient is going to live lesser at, like, the average life expectancy we know is somewhere around 70 to 80 years for most of the countries. So whether towards a fag end of his or her life, whether the patient is going to develop kidney disease, that answer, that remains actually unanswered with the study design. What we can say at least is, for 10 years, you're going to be safe. Your GFR decline probably is going to be somewhat comparable to that of the general population. Other problem is the dialysate. Not the problem. The other study is the dialysate study. Being an observational study, it has got a lot of maybe there might be confounding factors which probably was not captured in the system. Despite huge numbers, what we see is there are only a limited number of variables that has been studied. Now, the question is, this is a scenario where actually there could be a lead time bias effect. For example, someone who is under the care of a nephrologist right from the moment the person enters CKD stage 4, entering a dialysis program electively, and someone crash landing with a GFR of 10 or 8 to emergency department and starting on dialysis probably is going to have different outcomes. And the most important thing is, normally we know that most of the dialysis programs will have a sodium close to 138 or so. And why actually some of the patients were prescribed lower sodiums? So obviously there would have been some clinical indications, even though the baseline characteristics of the low sodium and the high sodium group appears comparable. We don't really have major data like the frailty status of the patient, how long the patient was under follow-up, was it an emergency dialysis or an elective dialysis, what was the nutritional status. There are so many missing data. So obviously this is from the Fresenius chain. They might not be having data on all these parameters. And I would say, rather than actually changing the practice of dialysate sodium with this study, we should actually wait for the RCTs to come. Of course, then not much of comments about the Acacia sub-study. It's a phase 2b study. The results are promising, and obviously phase 3 studies are going to follow. At least actually what we know from the current scenario, APRIL inhibitors looks like very promising. But again, the big question is, are they going to translate into an improved GFR at the end? So the same story with the old steroid trials. So they reduced proteinuria in the short term, but eventually at the end of 10 years, there was not much reductions in the GFR. So this is a question that needs another 10 or 15 years to answer. So anything more I should address? Is there anything else in the chat box?
Ma'am, I think thank you, ma'am. Thank you for such a very nice, crisp update of almost all the trials which were done. I think we are already running out of time. Thank you, ma'am, and thank you all the attendees for having been there for this JC. From next month, we'll be having our standard one, wherein we'll have a resident present, one journal club only, and quarterly we'll be doing an update. Probably we'll reduce the number of articles so that we can have a longer discussion.
Yeah,
so once again,
one suggestion is basically maybe we can discuss 3 articles with a little more focus on the study design, because that is which matters. Just reading the conclusion is not sufficient.
I think that we'll be probably doing it in the next update, ma'am. We are planning this on a quarterly basis. Otherwise, we'll do a monthly journal club where only one article will be discussed. That will be there from the next month. So I'd like to thank all the panelists and all the attendees for being with us this month. So we'll meet again on the 3rd Wednesday next month for interesting JC discussion. Thank you.